Okay, I have it at the top of the hour, so I think we're going to go ahead and get started, as I know there's a lot of content to be covered in this 90-minute session. So happy Friday, everybody, and thank you so much for joining us today for this really important technical assistance webinar talking about CMS and those restrictions that have been loosened up around telemedicine services during this COVID-19 time, and also looking at the impacts that that can have on your cost report. So I hope everybody is doing well during this time of constant change. I know it's been another very, very busy and hectic week, and trying to stay on top of all of these changes can be a little overwhelming, to say the least, for all of us. I'm Kate Stenyam, and I'm a program manager with the Delta Region Community Health Systems Development Program. So the Delta program is providing this webinar today. And I just want to give a reminder that the Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. So before we go ahead and get started, if everybody could just take a quick minute and find that chat box on the left-hand side and type in your name, your title, and your organization. That really helps our presenters get a good feel of the audience that's on the webinar today. So again, if you could find that chat box on the left-hand side and type in your name and your title and organization, that would be really helpful for us. Marla and I were just touching base before we got started today, and just saying how the timing of this works perfectly, because originally we thought we were going to try to have this webinar on Wednesday, and then CMS came out with more changes and guidance just yesterday afternoon, and so luckily we had it on Friday, so that BKD, who has been very closely monitoring all of these updates, could include that in the presentation today, so that we are the most current and up-to-date on all of the information that you guys need to know, at least as of May 1st, 2020. That's what we can say right now, right? So anyway, our presenters are really going to get into the details of this, but just a few highlights from the changes yesterday that I wanted to point out from CMS, that it looks like they're expanding the beneficiaries' access to telehealth services, and practitioners are now allowed to provide those telehealth services, including physical therapists, occupational therapists, and speech-language pathologists. That was really exciting to see. I know that I personally have gotten a lot of questions around that, and if that was going to change, so we're very excited to see that. And it looks like hospitals also may bill as the originating site for telehealth services furnished by hospital-based practitioners to Medicare patients, registered as hospital outpatients, including when the patient is located at home. So some really exciting things. They also had released additional guidance, I know, on the Rural Health Clinic and Federally Qualified Health Center billing, and providing some additional flexibilities in there. But with that being said, I'm going to introduce our expert speakers from BKD, and they're really going to provide that insight and the details that all of you guys need to be aware of to adjust to these changes, more changes. While I'm doing some introductions, Sinava, could you please pull up those polling questions? So I'll do some introductions, and if you guys could fill out those polling questions that Sinava is going to pulling up on the screen, that'd be great. So our speakers today are from BKD, and pretty much I think you on the line probably know BKD. Marla Dumm is a managing consultant with BKD, and she has more than 20 years of experience in the healthcare industry. Marla provides reimbursement and compliance audit services, as well as education to physician clinics, provider-based clinics, rural health clinics, federally qualified health centers, and outpatient behavioral health providers. Marla has CPC and CRC certification through the AAPC and CCSP certification through AHIMA. And she's also an AHIMA-approved ICD-10 CM trainer. Steve Party is a managing director with BKD and has over 16 years of experience assisting healthcare organizations with strategic, operational, financial management, and third-party reimbursement issues. Steve also consults with healthcare providers on important reimbursement issues, including special provider designations, strategizing on complex reimbursement issues, and conducting in-depth Medicare and Medicaid cost report reviews. So welcome to our speakers. I just want to thank them so much for being here today, and I know they've had to make a lot of changes even just from yesterday afternoon, so I really appreciate their insight and their guidance on this important topic. And with that, I'm going to turn things over to Marla.
Wonderful. Thank you, Kate. We're very excited to be with you today. And as Kate has said so eloquently, timing is everything. CMS literally dropped some of the significant changes that we have been waiting on for, I would say, going on 4 weeks now, with a lot of information that came through with varied changes to some of the existing waivers as well as a lot of the billing guidance. So we are very excited to be with you today to walk through as much of this information as we can and provide you some insight on what those new guidelines are. We have identified specifically those changes to the waivers, and we'll step through each of those as we can. And we are also going to spend a majority of the time talking about the telehealth and the virtual communication billing from a Part D perspective, or your hospital employed providers, for example, and then also on the rural health clinic side as well, since we know those entities are represented in the organization. And again, we appreciate the time today. As Kate said, and as we have really been saying since this public health emergency started, that the information from our payers continues to change daily, and it has slowed down a little bit, but CMS still has a lot on their plate in trying to make sure that access to health care and that a lot of the potholes that we usually run into are removed so that access can just really be smooth in providing services to our clients during this emergency or to our patients during this emergency. So having said that, we always want to include this disclaimer that as of today, this is the information that has been released. We really hope that there are not multiple more changes coming, but we did recognize as we were going through some of the literature last night from CMS that there are some areas of grayness there, that we have some information on our slides of what we assume that CMS meant to tell us to do, and I'm sure that CMS will be putting out additional coding information in the coming days, I would assume, because there will be questions. We're going to be with you today for about an hour and a half. I'm probably going to take a majority of the first hour to go through the changes in the waivers and the billing guidelines, and then I'll kick it off to my colleague, Steve Party, who will outline some of the cost report impacts on the RHC side. We are going to be talking again about the waivers and the billing guidelines, specifically the changes that came through yesterday. Specific to the telehealth and virtual communication services, to include some new information about use of audio only and how the payers are going to look at that. It does depend on the site of service and whether you're billing to Part B or whether you're a rural health clinic provider for primary Medicare as to how you will be billing. And then Steve will follow up with the cost report information. We do want to also just put a disclaimer in that the information that we're going through today is specific to primary Medicare. We're not going to dig into the weeds of the MCO plans, and we are working with Delta on putting together some additional training that will be potentially specific to the state Medicaid plans, but just to make sure that we reduce the confusion, we are keeping to primary Medicare for this specific presentation. So to begin with, just to give you some background, I'm sure that everyone on the line is well aware that there has been a lot of legislative movement as well as CMS instruction that has rolled out over the last 6 weeks on how healthcare entities are to not only provide services but also capture those charges and bill for those services. And that information has continued to change. We've had a number of pieces of documentation that have come out from CMS, including the HR 6074, which was legislative action, which included the 1135 waiver authority, which really gave us that first wave of guidance on things that CMS was basically going to open the barn doors on and really remove a lot of the walls that we're usually facing in providing services. That led to the Coronavirus Bill number 3, which was an additional layer of legislation passed by Congress that resulted in the CARES Act, where there was a lot of information, particularly specific to our rural health clinics and FQHCs, and then finally the interim final rule that was released at the end of March. MLN Matters SE 20016 was a significant piece of instruction that was released on April 17th, and that was specifically to instruct us on a first layer of billing for rural health clinics and FQHCs. And there were a lot of holes in that instruction, and so we have been anxiously waiting basically for the last 4 weeks for CMS to give us some clearer instruction. And really to say that CMS drastically changed those initial guidelines is the least I can say on that. There were some significant changes to how they put out that information. And just as an additional layer of information for you on the call, obviously you're probably tapped into your regional MACs and other sources of information, and there has been a lot of confusion out there across the country with us, with our clients, in regards to what the regional MACs have been putting out as education over the last 2 weeks. And a lot of that has been early release, really, from the MACs, as CMS has said. They really released the information too soon, and they did not wait for the final CMS instruction. So there are some holes between what the regional MAC may have provided in the last week and what was released last night. And I know even Noridian, I think, today had a session scheduled and canceled that because they needed to update their slides. So the information that we have today is from National CMS. That's really what we usually try to wait for, just to make sure we have it from the horse's mouth. So we have provided you links throughout this presentation for a lot of this information. And basically they issued the same SE 20016 MLN Matters. They just included the updated date of April 30th as the revised date for that document. So we'll start in with the waivers. There are several things that we just want to take note of just from a documentation perspective, and just some hit and miss items that you particularly on the hospital side, will find of interest. First of all, for the lab orders, when they're ordering COVID testing, CMS is instructed that they will no longer require an order from the treating physician or practitioner specifically. The order just has to be from a healthcare provider who is authorized to order such services under the state law. So it does not necessarily have to be from the treating physician. So that clears up some of the walls that may exist at this point about getting those orders in. They also went on to say a written practitioner's order is no longer required for the COVID test for Medicare payment purposes. And so I'm sure that Medicare will release additional documentation guidance on this, but I am taking that to mean that we wouldn't need to immediately put something into the medical record. I would assume there's going to be verbal orders that we're used to seeing, but I will be interested to see if Medicare releases additional information on that, just to clarify what they mean by saying a written order. I'm assuming that they mean that a verbal order would be appropriate, and they have not given any additional guidance on the either inclusion or exclusion of needing a provider's signature on those orders as well. So that opens that up a little bit from an order perspective. This was one of the areas that we were all waiting with great anticipation on the hospital side. The question, particularly from our hospitals with a provider-based non-RHC clinic, have had questions on how or when or if they can submit a facility component of that audio-visual telehealth service when the patient is at home instead of located at another healthcare entity and dialing in to your employed or contracted provider who is inside your provider-based clinic. And Medicare had really confused the matter by including in the initial interim final rule that a facility component would be recognized, but then did not go on further and tell us how to bill for it. So they've given us, oh, I'm sorry, I've got two separate subjects here. I was confusing myself. Let's back up. This slide is specific to collection of lab samples. Sorry, I'm so excited. I got ahead of myself. This was another issue as to whether or not a department or employee who is obtaining the COVID samples, the nasal swabs, et cetera, would be able to bill for that collection service if it was not directly performed by an independent lab. The language that Medicare had in the initial interim final rule was specific to payment of those G codes, specifically the G2023, for an independent lab. And obviously not all of our labs are independent labs. They're part of hospital laboratories. They're part of physician groups. Other entities are obtaining these samples. There's drive-through services being provided, and so that was a gray area. The language that was released last night says that CMS will pay hospitals and practitioners to assess beneficiaries and collect laboratory samples for COVID testing and make separate payment when that is the only service the patient receives. So we are inferring from that we will be able to bill that G2023 when your staff, employed staff, are doing the obtaining of those specimens. Now, I have included that HCPCS code G2023 because that is the only one out there right now specific to COVID specimen collection that's not related to a SNF. And so we will wait to see if Medicare puts that out as confirmed because they did not include codes in their instruction, but wanted to provide you with that update. So that is good news. The number of samples that are being obtained, that's a significant amount of revenue that's basically sitting on the table. They did include some information about pharmacists. There have been a lot of questions, especially on the Q&A calls, specific to ancillary staff, which pharmacists fall under that category, and whether or not they can either participate or assist with services during the COVID emergency. And the language is that pharmacists can work with a physician or other practitioner to provide assessment and specimen collection services, and those services may be billed to Medicare. Pharmacists also can perform certain COVID tests if they are enrolled in Medicare as a laboratory in accordance with a pharmacist's scope of practice and state law. And basically their objective was to open up access to point-of-care sites such as the parking lot services that we now have, the drive-thrus, all of these different testing sites that are being opened up for patient access. And those are operated potentially by either a pharmacy or some other healthcare entity. Of course, they have been clear to say that any state requirements do need to be met, but that opens up the door that you can include pharmacists in your ancillary team. I know that work done by nursing staff, ancillary staff, technicians are now available to be done under general supervision, and so you would be able to add those staff onto your care team. Physical therapy and occupational therapy, there are two sets of guidances that were updated for the therapy side. This one involves PT and OT, and basically just says that the therapists are able to delegate maintenance therapy to assistants in an outpatient setting, basically so that that can free up the therapists themselves to also work doing other services and providing beneficiary access. So I think there had been some questions from the provider side on what the assistants could do or whether those services would be billable, and I think this is opening this door to say that the therapists can indeed delegate those services as they would in general practice during this emergency. On another note with the physical therapist, an excellent piece of news as well about the fact that CMS did expand the list of eligible practitioners who may bill for audiovisual telehealth. They had kind of run into their own brick wall by including in the interim final rule and the CARES Act summary that when they added codes to the telehealth eligible list, they indeed had added a majority of the physical therapy, OT, and speech therapy codes, as well as a number of other behavioral health service codes, for example, but left off the PT, OT, and speech therapy staff as eligible providers, so we were up against a brick wall. In the meantime, we've been hearing numerous stories from a number of our clients across the country about the thousands of claims that are sitting there waiting to be billed. So this is excellent news. I believe this goes back to March 1st. I did not include a date, but the links that I have, you want to really be sure to read through that information as far as what effective dates are, because there are varied effective dates that Medicare has rolled back the effectiveness to. A majority of them are back to March 1, so you want to verify on that. But they did add physical therapists, occupational therapists, and speech language pathologists now to the list of eligible providers. Excellent news. So basically, if a PT, OT, or speech therapy service is rendered over audiovisual technology, then the CPT or HCPCS code that represents that service that was rendered may be billed. If a PT or OT or speech therapy service is rendered over a phone or audio service only, then you will still be billing that G2012 or G2010. G2012 is the phone-only telehealth, and the G2010 is if the patient would be sending them pictures, for example, to assess or information to assess and then get back to the patient over the phone only, then that 2010 would be used. So those codes are still in play. There are also a set of CPT codes that would also be used for potentially some of your other payers that are not primary Medicare. And the links to this update are included on this slide. Here's the slide that I jumped the gun on just a little bit, is the billing for the facility component or the originating site fee. And their scenario is basically, since the patients are at home, but they may be calling in or communicating through audio-visual telehealth with a provider who is located in your provider-based clinic. And there was the question, particularly for primary Medicare, because for our critical access hospitals and PPS on the phone, you are split billing those services. On the critical access hospital side, you maybe do method 2 billing, but you're still splitting that facility service and the professional service. So Medicare has basically now said that hospitals may bill as the originating site for telehealth services furnished by hospital-based practitioners to Medicare patients registered as hospital outpatients. I think that they are making very clear that that would have to be a registered hospital outpatient, even though the patient is at home, including when they are at home. Now, this is another area that they did not go the extra step to say the Q3014, which is the originating site fee in the usual circumstances, would be billed, but we have included it here, and we anticipate that Medicare will probably have to issue a clarification. But we infer from this guidance, since this is the only code that is tied to an originating site fee, regardless of payer, that this is what Medicare is inferring. That Q code would be billed just as if you would, if you were calling out to another entity elsewhere and you were housing that patient physically in your provider-based clinic. And the reimbursement will be a fee schedule reimbursement. It will not be based on APC, nor will it be based on cost. It is a flat fee schedule payment of $26.25. So that is excellent news. I know a lot of entities have been holding claims. Okay, we're going to move on to the larger topic, which is basically our telehealth and our virtual communication. And just to refresh your memory, there are 3 distinct categories of virtual communication and telehealth. Telehealth is kind of the umbrella that everyone refers to this remote communication as, but there are 3 distinct categories. The first is an audio-visual telemedicine service. This is basically a substitute for an in-person evaluation and management or other type of visit, such as behavioral health, or now we can say with confidence the physical therapy work, a lot of the behavioral health services, annual wellness visits, things like that that are in the list of acceptable or eligible telehealth codes that are maintained by CMS. We always want to make sure that you know that you need to refer back to that most updated copy of the list to make sure that the code or the service you have rendered is actually eligible for telehealth. They're mostly in that evaluation type of service. There is synchronous, which is our two-way or real-time, where there is no interruption in the communication. It is real-time audio-visual, as well as asynchronous, which is more of a store and forward type of technology, where images or documentation is really sent to the provider, and then the provider responds at a later date, and it's not a real-time communication. The new piece of information, as we've already shared, is that audio-only E&M services will be allowed, and it will just be dependent on what setting you are in as to how that will be billed, and we will walk through that. We also still have our e-checks, and there has been a lot of confusion with the phone-only services because an e-check is actually a phone service. It is initiated by the patient. It is a very brief 5 to 10 minute call, and basically is used to triage. The patient may be calling in with some presumptive COVID symptoms, for example, and the provider will assess those symptoms and then triage as to what next steps should be. Should you quarantine? Should you go to a testing site? Should you come into the hospital or clinic? So it's basically a triage. That's how we've been kind of separating the thinking about those two. There's also some caveats on those e-checks that they're not related to any E&M service that the patient may have had in the prior 7 days, and it would not result in a scheduled appointment within the next 24 hours. If either of those have occurred, then you would not bill out that e-check because it's considered bundled to your other charge capture for the face-to-face visits. And then finally, we have digital or portal e-visits. These are very common, particularly in our hospital systems, where there is really patient portals set up that have some type of communication, whether access to audio-visual or whether it is literally just a digital email system back and forth with your provider. That guidance is that you have to have at least 5 minutes of time spent communicating back and forth within a 7-day period. So this code or this service may not be billed more than once every 7 days, and you just continue to accumulate time. And we'll go through some of the different codes that are related to that based on your site of service and obviously payer. So when we break these down a little bit further, let's break down some of the billing and the guidelines for audiovisual telehealth. We'll start with that. Audiovisual telehealth has 2 components. The first is the facility component or the originating site. The second is the distant site, which is basically the professional service that's rendered by the provider that is connecting with the patient. Now, prior to COVID, there were some very strict guidelines in order to even set up or utilize telehealth. In other words, the patient had to be located in a rural area, a health shortage area, a non-urgent or non-urban or non-metropolitan area. It was very distinct because telehealth really, in its core, is to serve those patients who are in an area without adequate access to care. And so that's what the objective of telemedicine has really been from the start. And so there were some restrictions that were lifted as part of the public health emergency. One of that is that the patient can be anywhere. There is really no restrictions now on where that patient can be. They can be located in rural or urban. They can be at their own home, which was added at the very beginning of this process as an eligible originating site. The patient may also present to an eligible healthcare entity, and there are going to be those occasions where the patient physically comes into a clinic or a healthcare entity and then dials out to the provider elsewhere. So all caveats of patient location are pretty much open, and that has been in effect since March 6th. And again, this is the facility component, and this is why there was the confusion on the hospital side in those provider-based department, because that part of that global service was missing, yet you as the hospital were really still providing some of that overhead. You know, ancillary staff maybe have been participating, equipment costs, et cetera. And so that had been a concern. So we really will have 2 scenarios. One, will be billing for a patient who is physically presenting to a healthcare entity. The code that is billed will always be Q3014. And I have some various scenarios here based on where that patient may have been located. In the clinic setting, in the independent type of clinic, you would be billing on the 1500. The place of service code under Medicare instruction for this emergency will be the site where the patient would have been or is. Would have been or is. So that might be 11 for office, or 22 if they're in your on-campus provider-based clinic, 19 if they're in the off-campus, 23 if they're in the emergency room. You can see where that is going to assist in driving the appropriate reimbursement, particularly on the professional side. In the rural health clinic, specific to this discussion, you are going to be billing that Q3014 on a UBO4 using your 711 type of bill. For any FQHCs who might be on the call, 771 is the type of bill in that setting, and under revenue code 780. You do not need a modifier in the RHC side, so you won't need 95 or GT or CG because that was not pertinent to this code because it's paid under fee schedule. If the patient is physically located in the hospital, you would use the hospital outpatient UDO4, usually a type of bill 12X. Make sure that you assign a type of service 9, and then use the revenue code that's associated with the site of service for where they are physically located. If you are a critical access on the call, Medicare does require that you append modifier GT. That is the only occasion where they've still required a GT modifier, and that's a critical access hospital setting. This is also paid under fee schedule, and you'll get a flat rate of $26.65 regardless of where the patient is located. Another comment is that in all Medicare billing on Part B side, 80% comes from Medicare, 20% comes from the patient. And we'll talk about cost-sharing waivers in later slides, but that cost-sharing portion is what Medicare is also open to covering for some of these services. We also have the scenario if the patient is at home when they're initiating this audiovisual communication. And based on the guidance that we had received in April, actually last night, April 30th, we're now in May. The language is that hospitals may bill as the originating site for telehealth services furnished by hospital-based practitioners to Medicare patients registered as hospital outpatients, including when the patient is located at home. So that process of registration is probably already going on, but Medicare is making sure that you understand that even though the patient is not physically in your location of a provider-based clinic, your provider is, and that patient still needs to be registered. The Q3014 would be billed by the hospital on the hospital outpatient as we outlined prior. And again, the revenue code would be for where that patient would have been. So would they have been coming into the provider-based clinic, you would use 510. Reimbursement again, $26.65. Okay. Now, this guidance that we're talking about on billing for this facility charge, that Q3014 when the patient is at home, again, this is specific to CMS guidance. Now, we have seen that there has been a lot of trickle down from Medicare guidance onto some of the other payers. And I know that some of the state Medicaid plans have also said that they would recognize a facility component billing when the patient is at their home. So I think we'll continue to monitor that actively to see what the payers are going to be doing. But we always recommend that your billing office do reach out to your various payers, especially based on this guidance, if you are not already aware of what their rules will be in regards to billing any type of a facility charge, particularly if you have a contractual agreement with that payer to split bill, for example. Then we have the distance site, and this is really where a majority of the confusion has been on the billing as what our professional staff should be capturing when they're providing an audiovisual or phone telehealth service. So really some of the definitions are that this is the provider that is communicating with the patient over audiovisual. On the upper right-hand corner of the slide, this is a list of the original practitioners that were listed by Medicare as eligible to provide telehealth. You'll note that that initial list did not include the therapy side or any other provider that may fall into kind of that qualified healthcare professional, that they're more ancillary staff. In some circumstances, they're really not providers that usually bill evaluation and management type of services, and that's why, or behavioral health services, and that's why they were initially left off the list. In the larger shaded box on the right side of the page, we have indicated some of this progression in guidance. So effective on March 27th, under the CARES Act, CMS really removed some of the restrictions, particularly for our rural health clinics and FQHCs. They, to date, had not ever been allowed to do distant site telehealth. They could be an originating site. You can house the patient there and call out, but they did not have the ability to bill primary Medicare for professional services for a patient who may be elsewhere calling in for some of their specialty services. So this was a huge change and a great movement in the right direction for our rural providers. On guidance that was received last night, of course, we've talked about the fact that CMS has now added our therapy providers to that list of eligible distant site providers, so that's very exciting. And then also that CMS had expanded telehealth, that definition of telehealth, for the emergency to include phone or audio-only E&M telehealth services, with the caveat that this is when a patient has no access to audiovisual technology. They still want to make it very clear that they really are not advocating that providers are just calling the patients, maybe just to touch base or talk about a lab result and call that telehealth. This is truly an evaluation and management service that would have ordinarily been done in person or over audiovisual, but that patient is not able to obtain or access audiovisual equipment. And we have a lot of patients in the country who are in very rural areas. They are only left with landlines or inadequate internet access. So we know that this is a good move in the right direction. CMS also updated the list of telehealth services last night, and they really went a little step further because there are some services that are still noted as eligible for phone only or not. And because we're saying that, because there are still some guidance on some of these codes for the professional Part B side, where the code that is submitted will not be literally the E&M service, but it will be the 99441 through 99443 series for an audio-only E&M service. Those code descriptions are specific to that. And from the information we have gathered through reading the education last night, they are not telling the providers that they can automatically add an E&M service on. They'll be able to bill these 99441 codes, which were still kind of up for grabs. But they are also making a change just internally at CMS, that they're going to be really making this list an active working list instead of just updating it at the time of the final rule every year. They have understood that there is significant feedback they've obtained over this time from the provider side, and that they need to act more expediently on changes to the telehealth list, as well as opening up those guidelines to capture some of these very complex services that are now able to be done virtually. And so they are going to make this more of a working document and will consistently update it. So wanted to bring that to your attention as well. So first we have guidance on billing for Part B, and again this is for audio-visual telehealth. This will be on a 1500 claim form. It must be a service that is represented by a code that is on the eligible list. You will assign that CPT or HCPCS code. It could be an office visit code 99213. It might be now a therapy code. It might be a behavioral health service or something from a registered dietitian. But the code that you're rendering is put on the claim form. You will assign the place of service for where that patient is or would be located. So for example, if the patient is at home and they would have been physically in your office for that in-person visit, you would bill with a place of service 11 or 22 for that clinic site of service. The reason why they changed their guidance from the 0-2 that is still in place for telehealth to using the place of service where that patient would have been located is because they want to make sure that Medicare is pulling your reimbursement from the appropriate fee schedule amount, whether it be facility when they're in a provider-based clinic or non-facility for a freestanding clinic setting. And again, that is really pertinent when the patient is in their home and they're not physically located in another site calling in. Okay. Now, going forward, thinking past COVID, in the post-COVID, I think Medicare will revert back to the 0-2 because we don't know if they're going to continue to allow patients to be at home, although we really don't know. This has opened up so many opportunities for telehealth that it could be that some of these rules will be retained. But right now, the guidance is bill for the place of service where that patient would have been located if they are actually at home when the service is rendered. You will append 95 modifier to the codes on the claim form, and then your service will be paid under the appropriate facility or non-facility fee schedule allowance. Again, this is a service that will be open to that waiver of coinsurance, and so that 20% that would normally be patient responsibility would be eligible for waiving if the service was related to COVID and related COVID testing. Our guidance for phone-only evaluation and management services, this was in part of our original guidance where they kind of opened up that 99441 through 99443 series for the Part B side. You are still going to bill that on a 1500 claim form. You will use one of the 3 codes in this range, and this will be based on time. And so the time will need to be documented in your visit charting. 99441 is 5 through 10 minutes, 99442 is 11 through 20 minutes, and 99443 is 21 plus minutes spent by the provider in that communication with the patient. You will again use that place of service for where that patient would have been located, and you will be paid off of the established facility or non-facility allowance for one of those 3 codes. And again, this is going to be the phone only, still has that caveat of they anticipate that this is for patients who do not have access to audio visual for that complete telehealth picture. We're going to jump now to audio visual billing for the rural health clinic side. And in the last several pieces of information sent out by Medicare, it has been very confusing, but they are working with a tiered or phased claims submission process through July 1st. Okay? We're going to talk about dates of service January 27th through June 30th of 2020. And you may be saying, why are we going clear back to January 27th? CMS really updates their systems based on a monthly or quarterly process. And so in order to make the updates to the system, which are still being made, so there may still be some kind of hang-ups on billing and filing, as well as processing, just because they are actively now updating their systems. They had to roll their active date in their systems back to January 27th. So basically the June 30, any claims that you have ready to drop up to June 30th in the rural health clinic setting, whether freestanding or provider-based, you will bill the distant site service on an RHC UB. The code, again, must still be on the eligible CMS list. You will assign HCPCS code G2025. This is a change. The guidance that came out on April 17th indicated we were to assign the E&M service code. That has been changed for the rural health clinics. So we will assign the code that they have now set up for a rural health clinic audio-visual visits, E&M, G2025. You will modify it with CG. That's our payment code on the RHC side. So that, again, will prompt the payment. and then also 95 modifier, which is optional. I probably would recommend just going ahead and putting it on there to begin with, just to make sure that you're getting through all of the edits, but they have indicated it will be optional up through June 30th. And that modifier really is prompting that in addition to the G code as a telehealth service. Now, the services are initially going to be paid under your rate, under the all-inclusive rate. This is where it gets a little tricky. So this is because they don't have their system set up yet to pay at the amount that they have set up for a telehealth visit for RHC, which is actually $92.03. They don't have their system set up yet to roll out that amount up to June 30th. So they'll initially pay you the all-inclusive rate, okay? And we'll talk a little bit about how that's going to be reprocessed. Because on July 1st, Medicare is going to reprocess from their end any of the claims that they've received for telehealth up to June 30th. Okay? It's not going to be your e-checks or your G0071 claims. It's only for this G2025, which is, I think, another reason why they went with the HCPCS code, because from a reporting perspective, they can easily pull that out of their files to determine reimbursement reprocessing. They're basically going to calculate the difference or the additional monies owed based on what they paid you initially. So if your encounter rate at this point is higher than $92, they will consider that they've overpaid you in this interim period. And they will calculate the number of cases that you filed and multiply that number, and they will ask for that money to be recouped. That will be a one-time process. They're not going to recoup it against additional remits going forward. That'll be just a one-time, you owe us a check. If they pay you less than $92, then they will do the opposite. They'll calculate what they owe you and then cut a check so that they can round you to that $92.03. Okay, so that's what's going to occur for filing up to June 30th and for the reprocessing that they're going to do effective July 1st.
Marla, I want to jump in here.
Oh, yeah.
Yeah, can I jump in here real quick? Yeah, this is Kate again. So Joshua Gilmore, he's our CEO at Iron County Medical Center, and that's in Pilot Knob, Missouri. And so he had prompted a question before in the chat box and said, why is anyone excited about the telemed? Medicare's not paying our costs based on our all-inclusive rate, but rather some arbitrary rate that is further undermining our financial viability here in rural health. This is a travesty, not a win. So, Joshua, I wanted to open that up to you, too, if you wanted to bring in some more detail around what you're seeing there and this concern. And just a reminder, it's *2 to unmute your line.
Yeah, and absolutely. And I know Steve is probably going to be addressing this through the cost report because this has opened up a lot of issues. Not only this process that they've put in with the phase where we're going to pay you your rate, but then you're going to have to pay that back to get down to the $92. And we know, especially for the provider-based side, that that number is going to be significantly lower than what you're getting now for a quote-unquote visit. They still differentiate a face-to-face visit and a remote visit. They're not considering those one and the same. And I think that's why they, versus maybe a state Medicaid plan, decided to pay fee schedule amount versus the rate. And if this continues and we're allowed in the RHC side to be a distant site provider after the COVID emergency is over, it could be that they're going to change their mind and go to a rate. But yes, there are some significant concerns. Steve, if you're on the line, did you want to go ahead and address some of those now, or? See if he's unmute. It's *2 to unmute yourself if you're on the line.
Can you hear me, Marla?
Yes, you're on.
Yeah, I will address it. I will address it later. I think it is a concern. But I'll
very
definitely
good.
cover it in the cost report section.
Okay, wonderful. Because I know even internally, we've all had discussions really up to date about how much of a financial impact this is going to be. And we agree that CMS continues to really not fully reimburse the RHCs for the amount of work that they're doing and the population that they're serving. We agree with that. We're totally in agreement with that. So this is not the best solution, and I think part of the confusion is because they've not updated their system and they dropped the guidance before they were ready to go, which caused issues. We also have had conversations with multiple folks around the country, and CMS also on some of the Q&A calls has said that if you want to hold claims till July 1st to avoid this whole recoupment, overpayment nightmare, that would kind of solve some of those back-end issues of adjudicating everything, you can hold the claims until July 1st and then drop them. And they will process based on the instructions that we have for July 1st and past, and you wouldn't at least have to go through that issue. But we do agree that the dollar amount is significantly lower than we expected it might be. So Steve will address that during his section, and obviously we'll address any other questions that you have today as well, and that's a very good point. Thank you very much. From July 1 on, then, your claims will be very similar. The only change will be that you will not report the CG modifier. You're just going to have that G2025 on the claim. You will have the option to either append or just omit the modifier 95, and then again, you'll be just automatically paid at that $92.03. Okay. Now, the reason they adjusted the $92 to the $92.03 was because they were taking into account the telephone-only evaluation and management services. And similar to the Part B side, what they decided was that they were going to recognize a reimbursement amount based on the average of the reimbursement for the 99441 through 99443 series that we just talked about with the Part B side bills. And this is for the telephone-only evaluation and management services when the folks don't have audio-visual equipment access. Okay, so they bumped it up 3 cents. That seems really low to me. I would have thought it might be a little bit higher than an additional 3 cents to accommodate the phone average allowance, but I don't know what they did with their calculations. They do have some caveats on these phone calls. They pretty much left the rules similar to what an e-check is, which is about you have to have at least 5 minutes of conversation with that patient. I know a lot of the providers are spending a lot more time than that on the phone, which is going to be, from a time perspective, more accurately reported on the Part B side because they're able to bill all 3 of these codes based on the time that they spent. But for the rural health clinic setting, Medicare is going to ask you to bill the G2025 for either a audio-visual telehealth service or a telephone E&M service. You'll bill the 2025 under the guidelines on this prior slide for either scenario. Okay? Now, they do have this caveat again that if you have a phone E&M service that's related to an E&M service that was in the prior 7 days, or you see that patient in person within the next 24, they're still not going to ask you to not bill that phone call. We do want to also remind that CMS has been very clear that this is not for providers calling up a patient to talk about test results or just to check on a prescription refill or just a quick follow-up. They're trying to be very clear that these telehealth windows have been opened, but that they are truly for evaluation and management services and or behavioral health or therapy services. They are not for a quick phone call other than a patient-initiated e-check, which is billed separately, because they have great concern that that might kind of get ahead of ourselves if all of that starts. So I just want to put that caveat on that, even just because CMS has repeatedly reminded us about that on the Q&A calls. As a visual aid, this is just some cutouts from the MLN Matters that came out yesterday, and they just visualized what your data will look like on the claim form, the UBO4, for primary Medicare, and the dates of service depending on when your claims are dropped. okay? And again, they have been open to, if you want to hold your claims to July 1st, if you're able to do that, recognizing that a number of healthcare entities across the country are financially struggling and probably cannot wait for July 1 and need to have some money in the door. But the recommendation has been made, if you drop it prior to the 30th, just know that that percentage of money that's over your rate, you'll want to kind of hang on to that money because you'll have to pay it back to Medicare if that's the scenario for your hospital, RHC. Some additional information about the cost-sharing waivers, that is still in place. That is a modifier CS, and Medicare's information is that this will be effective for services furnished on March 18th, 2020 through the end of the healthcare emergency. CMS is anticipating to pay all reasonable costs for the specified categories of any evaluation and management service if that service results in the order for or the administration of a COVID test and relates to the furnishing or administration of such test or to the evaluation of an individual for purposes of determining the need for such test, including applicable telehealth services. So in other words, you are allowed to use the CS modifier on a service code that is related to COVID. We have had a lot of questions about this, and I'm sure there are hundreds of different scenarios. One that I can pull to mind is a case where the patient may have received orders for not only COVID testing but also flu, and the patient came back was negative for COVID but positive for influenza. That service would still be eligible for cost-sharing waiver because the evaluation was based on symptomology that could have been COVID, and there was an order for testing. So that's a scenario as well. Medicare, as part of their claims processing, it sounds like they're going to initially pay the co-insurance applied, and then the MAC will automatically reprocess claims beginning July 1 for the full allowance. So again, Medicare, which we often see when really expedient changes are made to their guidance, it takes a while for them to get their systems updated and the edits set in. So just take that into consideration. We always have had this question, and this continues throughout, as to whether a provider who is working at home can bill for telehealth or any kind of virtual or digital communication. The answer is yes. That was answered on very early as part of the waivers and the interim final rule. An initial comment on that is that you do not have to go through the additional hoops of updating any enrollment information in Medicare system if they are working from home temporarily or as part of this healthcare emergency. You would bill their service as if they were standing in the clinic or the site where they would normally practice, is how the instruction has come down from Medicare. So yes, they are eligible. They have to be licensed in the state that they're working. There has been some questions about services rendered to providers in another state or across state lines. And the caveat on that from the legal community is that you would still want to do due diligence and check with that state's scope of practice to make sure, or their state boards, to make sure that it is okay for them to render services to a patient in another state while not being licensed in that state. Medicare has said they're fine with it, but the legal community has been very clear that it's probably to your benefit to double check before you start providing services. We'll finish up this section with the last two pieces of remote communication. The one is a virtual check-in or an e-check. And for Part B side, this is again a communication that is initiated by the patient. They are calling in with a question or symptomology that they basically need to be triaged or assessed in order to know what to do. It's a very brief phone call. It is not a full-blown evaluation and management service. These are also circumstances where the patient may call into a queue, initiate their request, and the physician or the provider who is manning that queue may call them back, but it has to be initiated by the patient to be considered an e-check. This is a brief 5 or 10 minute call. Can be for new or established patients, which that door was opened up for not only the audio visual but also all of these virtual communications, that it can be with new or established patients. And again, these services do have that caveat of not being related to a prior visit within 7 days and or does not result in a scheduled appointment within 24 hours. If so, then this G code would not be billed. You have G2010, which is the review of images or documentation that might be remotely sent to the provider for review before that phone call takes place or that triage. And the 2012, which is literally the phone call, the real-time phone call e-check. So that service is still eligible, and those HCPCS codes are specific to Part B billing for primary Medicare. For the rural health clinic side, that same e-check, they are under the same criteria, but they will report G0071. Medicare put this code specifically in place for rural health clinics and FQHCs effective in 2019. So this code has been eligible for billing for quite some time. So Medicare basically took the average of the payments for the other Part B G codes and established a dollar amount for the G0071, which we have on one of the next slides. So that G code is still eligible for billing if you have an e-check, not just a phone E&M service. The last category is the digital e-visits, and this is basically a portal visit where everything is over the internet. And for Part B, the guidelines are that the patient or the provider would be spending at least 5 minutes or more over a course of 7 days providing online services, particularly if for the same condition. I know there is still a bit of a question out to Medicare as to whether a new time frame would start if the patient called within that 7 days for another problem completely unrelated to the prior conversation or digital access, but that question has really not been answered. But you do need to be aware that for an RHC, that G0071 can only be billed once every 7 days, and likewise on the Part B side, they would not expect to see these digital CPT codes, which are 99421, 99422, and 99423, to be billed out more than once every 7 days, because that's part of the CPT instruction. Those are also for new and established patients. On the RHC side, you're going to fall back to the G0071, which is on that last bullet point. The CPT codes are taken into consideration as into the calculation of the dollar amount, the fee schedule amount that CMS assessed for that G0071. And because they added in the digital e-visits into the consideration of that dollar amount, they did increase the dollar amount from like $13 up to the price that we have now for that G0071. A consent does need to be obtained. I have the G0071 here, but really for any of these virtual communications, a consent is required. And they can be verbal. They do not have to be written. And really some of the OIG and the governmental instruction really has allowed, as well as the CMS interim final rule clarified, that, for example, your ancillary staff, such as your nursing staff, can be on the line before the provider gets on the communication line and obtain that verbal consent and document that in the medical record at the time that service is being rendered. It does not have to be obtained prior to that service being rendered. The only caveat is that that consent does need to be in the medical record before a claim is dropped. But they have opened it up to make sure that you're fully aware that your ancillary staff under general supervision, which means there just needs to be a provider available basically for general supervision, they are able to obtain that verbal consent from the patient, whether over the phone or whether they're over that audio-visual communication or through the digital portal. The reimbursement for the G0071, which is again specific to the RHC setting, is again for virtual e-checks and for portal or digital visits, and is now set at $24.76, which is an increase from the $13 that they had initially established earlier on in the year. Again, we were focusing on primary Medicare today. There's enough to really confuse yourselves on just Medicare, but just know, as you are probably more than familiar with now, every payer has different guidelines. Some will require different codes. Some will require different places of service. They may universally want the 02 for any telehealth or remote services, and there are different modifiers that they are requiring. So I would just remind that if you have your primary commercial and MCO plans, that you already have obtained or need to obtain the telehealth COVID instructions that are in place. Every payer pretty much has that as on their main web page of the connection to their COVID instructions, and that's really what you want to look for. And for the rural health clinic side, I know we're going to be digging into some of the state Medicaid guidance for you just for clarification purposes, but you really need to have a tracking tool available, keeping straight all of these different payers because they are all significantly different, and the reimbursement is also different. I know to the point that Steve will speak to about the cost that's been assessed on the telehealth side at fee schedule for RHCs versus the rate. We were surprised, quite frankly, that Medicare went to that, although the originating site fee of that combo service has always been paid under fee schedule. Medicare has never historically considered that to be the same as a face-to-face in-person encounter, regardless that an E&M service is being rendered. And I think that's some of the potholes that CMS is looking at, where on the state Medicaid side, we saw a majority of the states say that they would pay that under the rate. So it's just a difference in opinion between both federal programs. And we'll be hopeful that Medicare will move that forward to a rate payment if they allow us to continue this service post-COVID. And with that, I will roll this over to Steve for some cost report information. We appreciate your time so much today.
Thank you, Marla. So yes, you know, the expansion of telehealth services for rural health clinic is going to have an impact on the Medicare reimbursement for rural health clinics. You know, as Marla reiterated, Medicare reimburses based on an all-inclusive rate, and that is typically defined as a face-to-face visit with a physician and a nurse, a physician assistant, nurse practitioner. The all-inclusive rate excludes services such as chronic care management and telehealth services, primarily because they're paid on a Medicare fee schedule. For freestanding rural health clinics and rural health clinics that are provider-based to a hospital with greater than 50 beds, their all-inclusive rate is a flat $83 per visit for calendar year 2020. For rural health clinics provider-based to a hospital with less than 50 beds, including critical access hospital, the all-inclusive rate is the cost per visit subject to productivity limits. One thing that I want to that came out in the MedLearn Matters that was released yesterday for rural health clinics that are provider-based to a hospital with less than 50 beds, including critical access hospitals, CMS is allowing those hospitals to increase their bed capacity to address the increased need for care due to COVID-19. And so to prevent rural health clinics that are currently exempt from the national per visit limit from losing their exemption, basically they're allowing those hospitals to go ahead and increase their bed capacity, and they're going to use the beds from the cost report period prior to the start of the COVID public health emergency for determining the exemption to the payment limit. So those hospitals with less than 50 beds that have a rural health clinic that gets paid on a cost per visit, if they increase their beds to say 55 beds or 60 beds for the emergency, they don't have to worry about losing that exemption and that cost per visit payment amount. So it's going to be extremely, because rural health clinics that are provider-based, you know, again with hospitals less than 50 beds and critical access hospitals, because they get paid on a cost per visit, it's going to be extremely important to identify and track those telehealth costs and the services that are provided. And I think, you know, those costs are going to have to be reported in what's considered a non-reimbursable cost center within the M series for the rural health clinic calculation. And I think providers are going to have to maintain some type of time study to determine how much time the physicians, physician assistants, and nurse practitioners spend on telehealth versus their face-to-face encounters. Because they're really going to have to capture that telehealth service time and report it in a separate encounter. Again, primarily because the telehealth visits are excluded from the rural health clinic's face-to-face encounter visit and that cost per visit calculation. So that's going to be extremely important. Just want to make sure I didn't. They've also stated during this public health emergency that they're going to reimburse the reasonable cost for E&M services if those services result in an order for an administration of such tests and relate to the furnishing or administration of such tests or the evaluation of an individual for purposes of determining the need for such tests. So they're going to, basically the way I have interpreted this is they're going to reimburse the cost per test related to COVID-19. This is similar to how rural health clinics get reimbursed for vaccine costs for pneumonia and influenza. So, and in those cases, the rural health clinics have to identify the staff costs, which includes any telehealth services, the staff time, the medical supply costs, and the COVID-19 test costs. And we'll probably have to provide some type of information. For the flu and pneumonia, for example, it does a quick calculation of what the cost per vaccine is. It allows for the staff time. I think this is going to be real similar to the vaccines where they reimburse this through kind of a separate mechanism within the rural health clinic cost report settlement. So it's going to be important to also track those costs as well. I think I'm missing kind of one slide in here that kind of the summary that I just kind of like to kind of go over. You know, for rural health clinics, that cost per visit is calculated when you take total cost divided by total face-to-face visits. So again, that cost excludes any telehealth services. It excludes the cost of those services. It excludes those visits because, again, you will only want to track you're going to want to track your telehealth visits separately from your face-to-face encounter visits. The other issue on the Medicare cost report is when you put costs into that telehealth cost center, the rural health clinic, for a hospital-based rural health clinic, gets a piece of the hospital overhead. And that overhead is included in that cost per visit. When you put the cost on the telehealth line, it's going to absorb some of that hospital overhead cost. So it's going to be pulling away some of that cost. So it's going to dilute your cost per visit for your all-inclusive rate going forward when that's calculated. The other issue that you need to factor in is, again, there's the productivity limits for rural health clinics where physicians need to see 4,200 visits per FTE, and nurse practitioners and PAs need to see 2,100 visits per FTE. There could be productivity issues that arise when you start providing these telehealth services. Again, that's why it's going to be extremely important to maintain time studies between the face-to-face encounters that are performed in the rural health clinic versus telehealth. So not only tracking the salary costs, the service costs, and also tracking the visits separately and also the practitioner time separately. You know, all of this can add to a combination, a multitude of scenarios where it's going to have an impact on that all-inclusive rate going forward when you file your next cost report and how they set that rate. So it's going to be like I said, it's extremely important to track these costs and to report them separately, to identify them the best that you can in order to separate what's reimbursed as a cost per visit, what's reimbursed on a fee schedule from telehealth services. With that, I'm going to, Marla and I will open it up to any questions that you guys may have.
Again, just a reminder, it's *2 to unmute your line, or you can use that chat box over on the left-hand side to put a question in as well. Well, I see some people are typing. Well, some questions are maybe filing in. And ask Zinaba, we have some post-polling questions as well. To pull up those post-polling questions, if you could take a second and fill those out, that would be greatly appreciated. I know that this is quite a bit of information to digest, and it's changing quickly, and we have a lot of concerns, obviously, for our rural hospitals out there. So again, if you have a question, *2 to unmute your line. Marla and Steve are ready to answer any questions you might have, or please put a question in the chat box. If you're thinking about a question, it's quite possible that other people on the line are also thinking about that question. And I did just want to throw out there too. Yep, go ahead.
Oh, no, you go ahead, please.
Yeah, I just wanted to throw out there too. Let me know, again, if you guys ever, if you're seeing really specific issues and stuff we can help you with. Not only does it help me tailor some educational needs that we can put together for you guys, but it also, even though we are not, at the National Rural Health Resource Center, we are not the advocacy place for rural health. That's really done through the National Rural Health Association, as well as the National Association for Rural Health Clinics. But it's great to know these specifics and these concerns so that we can share that with those teams. If they don't hear it, they don't know. And they really do have a very, very strong voice in Washington. So if you're having these specific questions and concerns, the more information we can get to share with them and with our federal partners too, the better. So please just send me any specific questions or concerns that you might have. You guys are the ones that are in the trenches and who really are seeing every day, you know, what you're dealing with and some of the struggles that you have.
Yeah, we would definitely advocate that as well. We work very strongly with both of those national organizations, and as you've said, they have been a very strong liaison for you and have really significantly challenged CMS on a lot of these rules for the rural health clinic side. And, you know, no, is it a perfect answer? No, it's not. And we really hope that going forward, Medicare will first realize that telehealth is a vital service opportunity in the rural health side to serve some of these rural communities, and that they adjust accordingly to reimburse really accordingly and more similar to what the visits are. We're hoping going forward that that's what they're going to do, but we don't know at this point. Looks like Carol had put a question in chat. This is a good question. For provider-based RHC, what code would we use to bill a telehealth nursing home visit? You want to think of it just as if that patient was in front of you. So if it was going to be for just an office visit, you're going to obviously assign those office visit codes. They have added the nursing facility codes to the list of eligible visits, as well as hospital services as well. Emergency visit codes are there now. The admission codes are there, subsequent day codes. So if your providers are doing telehealth with a person who is in a nursing home, that's technically a nursing home visit. So you would bill the nursing facility code. And I think you really want to think about it is, would that patient have come in? Would they have been able to come in? Or literally, would you have gone to the nursing facility to see that patient? And that will assist you in what CPT code that you will assign for that telehealth charge. And then again, you'll just apply the, oh, I'm sorry for the, I'm getting myself confused. For the RHC side, you're still going to fall back to that G2025. but the charge that you put on that will be for the nursing facility code. Yes, you're going to have that G2025 that's specific to primary Medicare, regardless of what service CPT code that you might have rendered. It's going to go through as a G2025. But the charge should be tied to the correct CPT code that would have been billed. If you're doing this for some other payer, then you would be billing the nursing facility CPT code. The provider would have visited. Oh, okay, you clarified that. Thank you. And then Holly had a question on for a facility to build a Q3014, where must the patient and the doctor be located? This is part of what's changed. In the prior to COVID world, the patient was always required to be physically in a healthcare entity, whether they were in a clinic or an RHC or in a hospital setting. And then they are dialing out basically to a provider that's outside of usually their system to another provider like a specialist. And that's the distant site service. So for the originating fee, you're basically assuming that facility component or technically housing the patient. And the curveball that's been thrown is that now they've opened that up so that the patient is able to be at home just due to the fact that they're trying to reduce exposure. So that's the only reason they opened that up to a home setting. Based on the guidance that we received last night, they are saying that in a facility setting, if your provider in your provider-based clinic, for example, is the one who is rendering that distant site service and the patient is at home, we essentially don't have, in the normal scenario, a facility component because that patient is at home. So Medicare has answered that by saying they are going to allow the hospital that has the provider that's rendering that distant site service, and you usually split bill that quote-unquote clinic visit for primary Medicare, that the hospital can drop a UB for that Q code to reflect that facility component of that telehealth visit. Does that answer the question, or do I need to clarify better? So the scenario would be only if you have that patient at home. In the other scenario where that patient may physically actually go to a healthcare entity, wherever that patient is located is going to pick up that Q code. And if your provider is the one they're dialing out to, all that you would bill in that circumstance would be the distant site professional service. So the instruction we received last night is pertinent to only those scenarios where the patient is at home. The patient is at home and the doctor is home also. Holly has an additional question. Yes, the doctor is at home, but really in this scenario, you would bill that as if they were standing inside the practice where they usually are. So you're going to be really billing that as a provider-based clinic service. The patient is just, or the doctor is just at home. So again, yes, the hospital would be able to pick up that Q code as well as the professional service. I apologize on some of my confusion. I myself get confused with payers and sites of service with all of these confusing guidelines. It looks like Jara is typing a question. Jara has asked, because of these expansions via the waiver, do we need to append the CR modifier to indicate we are billing for these based on waivers? That's kind of a mixed question, and I did not include the CR and the DR instructions in this conversation today. I probably should have. The only reason I did not is because telehealth does not require the CR modifier on the telehealth claims for your professional services. The facility may have to issue that DR on the Q code, but we have not seen any indication of that because they really lump telehealth into a scenario of services that is not subject to the DR or the CR. Now, if the telehealth service is eligible for cost-sharing waiver, which means the patient would not be incurring any coinsurance or deductible, then the CS modifier would be appropriate. And you would append that to either the originating or the eligible telehealth distant site professional service. Kim's question, just a little bit more clarification on nursing home telehealth. I believe you said we would bill the nursing home visit 9930 and the G2025. Yeah, let me back up and clarify that because I confused myself with the Rural Health Clinic side versus Part B. For Rural Health Clinic, even though you may be doing that service for a patient who's in the nursing home, you are still going to be billing the G2025. You will not also assign the CPT code for the nursing facility level of service. Similarly, in the clinic or for a clinic type of telehealth service, you would not be assigning a 99214 in addition to the G2025 for the RHC primary Medicare side. That is something that they changed from the initial instruction we received on April 17th, where they had asked us to bill those actual CPT codes. And in the guidance we received yesterday, they changed that. So for primary Medicare, for any audiovisual telehealth service or phone-only E&M telehealth service, regardless of where that patient is and what that visit might have been, whether it's a clinic visit or a nursing facility E&M, you will report G2025 on the UBO4 alone. Up until June 30th, you will put the CG modifier with G2025. You can also append 95 modifier. That is optional. That's just an extra piece of information that makes sure Medicare assigns that as a telehealth, and then that will prompt the payments based on prior to June 30th or post June 30th, but really just rounded down to that new dollar of $92.03.
Hi Marla, this is Sineva. I just wanted to make note, 1 second, that the recording, the webinar will be recorded and we will be uploading this recorded to the website. So once that is uploaded, I will be sending out the recording and slide deck to you all to look back on as well.
Wonderful. Looks like another question is coming in. These are really great questions. And I also would just kind of put a little dig out there for CMS. I know that I will say, having worked in this industry for going on many years now, I won't say how many because that ages me, but I would say that this rollout of the COVID has kind of been a mixed bag from CMS. But I will say within the last 4 to 5 weeks, once they initiated some of these question and answer calls that they have weekly, I think that's opened up the communication barriers that we often have with Medicare. And I would say that if you're not tapped into those office hours phone calls that are literally Q&A on Tuesdays and Thursdays from 4 to 5 o'clock Central Time, I'd be happy to send you the information to register for those. And really, you don't even have to register. It just makes it easier to access. It's a web-based phone call because they have so many people that are across the country that dial in every week. But I will say not only does that bring you real-time answers from Medicare medical directors and niche leaders at Medicare, but it also gives you an opportunity to ask questions to Medicare, as well as listen to questions from others in the country who are really suffering through this along with you. And really, from our perspective, it just brings more clarification on their guidelines. They are very sure when they tell us no or they tell us yes. And if there is something that they have put on the table to consider and confirm later, they continue to give us that same answer, similar to the information that we've been waiting on for 4 weeks. That was their consistent answer, that it was still under review, that there were several barriers on their end they have to jump through before they can give an answer, and that they would have that out shortly. And I think that just brings a sense of at least we know they're working on things, and I really hope that CMS in the future continues to have this open forum for these types of huge areas of implementation that we really go through every year, particularly after final rules are dropped. Kate, just let me know. I'm happy to send that if it's not already a known source for your members, and I think everyone can really benefit from sitting in on those calls.
Yeah, Marla, thank you. That's great. We'll include that in the when Cineva sends all the information out about the recording.
Okay, great, because they have just been very, very helpful. They also have another call that's called Lessons